So why do we have that kind of problem? Well, part of it is we don't have a healthcare system. We have a loosely knit group of stuff that we offer. Not anything that really has been thought through carefully or organized. So when we attempt to remedy or reform, it's not always clear where we need to go first. As you've known from keeping up with the news, one of the big issues that Obama would like to see changed is that we have transformative technologies in healthcare. Health information systems that work, that give us information. If you've been in the hospital and you were there for 2 weeks and you leave and go home for 3 days and you need to come back and get information, the likelihood of their finding your medical record in that day is pretty slim. It might take 2 or 3 days. That generates the potential for medical errors. It compromises patient safety, and it puts you in a vulnerable situation. One of the other issues that's extremely complex is people don't know how to navigate the non-system. How do you navigate the system? What do you need to know? And one of the components that we don't see much in the literature that I hope the Obama folks will jump on is this whole idea of health literacy. The ability of patients to understand basic healthcare information. I always use the example of myself. My father is a physician. I was brought up in a medical family. I've been in the healthcare field for 25 years. And I once had a pain on my foot. So I went to an orthopedist after going to my primary care doc, and they told me I needed a surgery. Surgery didn't make sense to me, so I went to another orthopedics group, and they told me the same thing. And I kind of let it pass, and about a year later, I went to another orthopedics group. By the time I went to 4, they all told me what needed to be done. I needed a surgery. By the way, they were all surgeons, and if you go to a surgeon, if their only tool is a hammer, they see the whole world as a nail. So I could expect that I was going to get a surgical solution if I went to see a surgeon. So subsequently, I heard something else, and I'm just a decrepit guy, what can I tell you? And sure as can be, I ended up having to do some stretching exercises and have some physical therapy. And doing those stretching and physical therapy exercises made the pain go away that allegedly was going to require these surgeries. Now, I'm pretty sophisticated in this area, and I almost had my foot cut up because I didn't know better. The average American doesn't understand basic healthcare information. If you're given a pill and you're told, take it 3 times a day, and you pick it up at 2:30 in the afternoon, when do you take your first pill? Then? You double dose in the evening? Depends who you talk to. A lot of nurses will double dose. A lot of other people will all wait and get on a schedule the next day. Depends what kind of pill it is. And we're going to get a whole disparity of answers. I've even tested this out with people here that are graduate students, very sophisticated, and say, well, gosh, you know, one says this, one says that, one says this, one says that. The amount of money that we spend on healthcare literacy is amazing. The opportunity for errors with people that have health literacy challenges is 4-fold that of people that don't have health literacy problems. 4-fold. The billions and billions of dollars are lost every year in this area. Obama wants to try to fix some of these things. I mentioned his pre-existing illness requirement. He also wants to change the big picture. Like I said, we don't have any system. Part of what we do have as a system is we have diagnostic codes. We have reimbursement codes that are based on doing procedures. So we're in the doing procedure business. These were created by surgeons. Surgeons do procedures. People that aren't surgeons, they don't get paid as well. You get more if you do the procedure. We don't pay for cognitive services. That is, we don't pay for the physician to think, though there is some discussion about doing that sort of thing. But we really need to rethink our system. If we do have a system at all, it's not a healthcare system, it's a sickness system. We pay for sickness. We talk every so often a little bit about prevention. We talk a little bit about how we can save downstream costs if we act expeditiously, but we don't have that kind of system. And I think with information, I think with changing the way in which we reimburse for healthcare, I think by having an all-comers open playing field where everybody can have access to insurance, and I'll talk about that more in a moment, we can make a big, big, big difference. There's some interesting initiatives that are already going on. I mentioned the AHIP initiative about dealing with getting beyond some of the pre-existing illness requirements. There's another new concept that's emerging called the advanced medical home. This advanced medical home was created, actually it started in pediatrics. It was the idea that if you have very sick children, they need really, really good, careful care management to reduce downstream costs and to make life better for themselves. Notice I said cost first and care next. I've been in the healthcare system too long. The first thing we think about is money, and then we think about is care, which is perverse. We should be thinking first about caring for people. That's the ethos. And then we should figure out how to pay for it. And then find out what we can pay for and what we can't, or what we decide we're going to pay for and what we can't. Get rid of some of those barriers to give people access to healthcare. So I mentioned the Advanced Medical Home. American Academy of Pediatrics, American Association of Family Practice, American Academy of Physicians, and the American Osteopathic Association have all gotten behind this thing. And right now there's 200 demonstration projects that are going on with Medicare to see whether this is going to be adopted as part of a traditional Medicare package. So what they're doing is they're taking not what we've called in the past cherry picking or sifting the population to get the best patients. You know how that works? One of the jokes about managed care organizations that wanted to have a healthy population was to have your enrollment center on a 5-floor walk-up. And those who can get up there, they're in the plan. Those who can't, no. Well, this demonstration project takes those 15% of the people in Medicare that constitute more than 50% of the costs in Medicare. The sickest of the sick. One of the demonstrations is going on with a colleague in San Diego. The mean age she has is 84. Mean age is 84. So here's the incentive. If you participate in the demonstration project and you are efficient at what you do, and you are able to save 5% for Medicare, Medicare gets its 5% back, and you're clean. But anything over that 5%, you get to keep 80% of the profits. And the other 20% goes back to Medicare. So Medicare still wins either way. They got a 5% savings over what they usually would pay. They get whatever the residual is in terms of the money. And there are rewards or incentives in place for providers for using their heads and for coming up with more innovative ways of delivering services. And this has become very, very effective. It's saving money. It's better meeting need. It's giving some control to continuity of personalized care. And it's a shift. It's a shift away from the managed care era, which was a lot of denial-based mentalities, and disease state management. Let's manage the costly diseases. Let's manage asthma. Let's manage cardiovascular disease, rather than let's care for people. So the new model is a shift away from disease management to care management. Personalized solutions for individuals to walk them through the process and help them navigate the system. So if we have a shift to care management, if we're going to have better information technologies to transmit information, even organizations now that have very good health information technologies, and there's very few of them, they don't crosswalk or communicate with one another in most times. So even though I might come from a good health information system and I go to this hospital that doesn't have one, they can't get my data. So we need to have a way that we can have continuity, and there's going to be a lot of money poured into the system to deal with that issue.